Hello and welcome to Cardiology 101. This is Dr. Shiraz, and today we are going to discuss some ECGs of anterior wall MI and anterolateral wall MI and lateral wall MI. So first of all, we're going to discuss the criteria for labeling STEMi. Remember that we are discussing 10 millimeter per millivolt ECG, and I will discuss this later. What is 10 millimeter per millivolt ECG? We have two scenarios. We have anterior leads and then we have any other lead in the 12 lead ECG. In the case of anterior leads, if we have elevation in two or more contagious leads. What are contagious leads? Any lead that come next to each other. For example, V1 and V2 or V5 or V6 or V4 and V5. These are called contagious leads. Similarly, lead 2 and lead 3 are contagious leads. Lead 2, 3, AVF that represent the inferior lead are contagious leads. So in the case of anterior lead, we have a male that is aged below 40. We need at least elevation of 2.5 small blocks in the case of anterior leads. Similarly, if we have a male that is aged above 40, we should have elevation of at least 2.2 small blocks or more than 2 small blocks. In the case of women of any age, it should be at least 1.5 small block. So if it becomes difficult for you to remember all this, just remember that in the anterior leads, we need at least 2 small block elevation in any gender or in any age group. So I think that would be easy. In every other lead, if we have elevation of 1 or more small blocks, that would be significant. So let's just focus on what is 10 millimeter per millivolt ECG. So as we know, the ECG records our amplitude in millivolts. So our 10 small blocks are equal to 1 millivolt. Alright, so every small block is about 0.1 millivolt. So the significance of this is if the elevation is 0.25 millivolts, then it would be significant. But we have made it easier for us by referring it to small blocks. So what happens is if we have an ECG that is recorded at 25 millimeter per millivolt, then the significance would be of at least 5 small blocks or more than 5 small blocks. You understand this? Because the 25 millimeter per millivolt ECG will record higher amplitudes. For 0.1 millivolt of amplitude, we will need more small blocks to cover in 25 millimeter per millivolt ECG. The reverse happens in 5 millimeter per millivolt ECG. So let's just see some examples of how we can find whether this ECG is 10 millimeter per millivolt or 25 millimeter per millivolt or 5 millimeter per millivolt. So sometimes we do not see the headings above it. It is written on the heading whether it is 10 millimeter per millivolt or more. But sometimes we do not have that. So what should we do then? If we look at these blocks here, okay, these blocks, what they do, they tell us how much is 1 millivolt, okay. So in this case, this block is of 10 small blocks, 3 here, 5 and 3, 8, and these 2, 10. So 10 small blocks are equal to 1 millivolt. So our 1 small block will be equal to 0.1 millivolt and this ECG is recorded at 10 millimeter per millivolt. Alright, let's see another example. So if we look at this ECG, it is given to us here that this is 10 millimeter per millivolt. And we can confirm that by counting this block here. This is almost of 10 small blocks. So in this way, we can count whether the ECG is of 25 millimeter per millivolt or 10 millimeter per millivolt. So now that we have talked about the criteria for labeling STEMi, let's just look at ECGs separately and discuss it. So every time you read an ECG, you should do it systematically, going through every possible aspect that you can find on ECG. For example, rate, rhythm, axis, and P wave, and QRS complexes. But since we have a limited time for this video, we are just going to focus on the ST segment. So this is our block here. This is almost of 10 small blocks. So this is our ECG of 10 millimeter per millivolt. So if we look at ST segments from here, we see an elevation here. We discussed that only one small block elevation in every other lead is significant. So we have elevation here in the lead 1. Then we have ST segment in, then the contagious lead for 1 is AVL, high lateral leads. So we have elevation in AVL2. So these two contagious leads have elevation, which are our high lateral leads. Then we have ST segment depression in lead 2, 3 and AVF, which are our inferior leads. Okay, lead 3, lead 2, all these have ST segment depression. In lead 1 and lead AVF have ST segment elevations. Then we go to lead 1, V1, V2, V3, V4 and V4. Okay, what do we have here is ST segment elevation from lead V2, V3 and V4. This is also marked by hyperacute T waves and J point elevation. So this is our anterior wall MI and this is our lateral wall MI. These two combined are called anterolateral wall MI. What we have in inferior leads is reciprocal depression of those STEMi. So what is the significance of reciprocal depression? Well, it is a proven fact that those ECGs or those STEMi which have reciprocal depression accompanying them have poorer prognosis and they show decreased ejection fraction on echocardiography. Alright. Next up we have another ECG. So this again is of 10 millimeter per millivolt. We will start from lead 1. Alright. What we have in lead 1 is no elevation, okay. And in lead AVL we have no elevation at all. Then from lead 2 to lead 3 and lead AVF, we have ST segment depression. Alright. And if we look at V1, we have elevation here. We have elevation in lead V2. Alright. We have elevation in V3. And then we start seeing some depression. Okay. So what this is anterior wall MI. Alright. This is anterior wall MI with reciprocal depression in inferior wall. So this is our isolated anterior wall MI with some reciprocal depression in inferior wall MI. Okay. So you may be confused by these ST segment depressions. Well, these ST segment depression may be due to stress of left ventricle. Next up, we have this ECG. This again is of 10 millimeter per millivolt, as we can see here. Alright. We have one small block elevation in lead 1 and lead AVL. We have now discussed that this is significant. Then we have inferior leads. We see ST segment depression here and here and here. From V1 to in V1, we have hyperacute T waves and almost two small block elevation. Similarly, hyperacute T waves, ST segment elevation, hyperacute T waves, and okay, that's all. So this is our anterior wall MI, and this one in AVL shows our lateral wall MI with some reciprocal depression in inferior leads. So this is our anterolateral wall MI. So you may ask why lateral wall MI is accompanying anterior wall MI so frequently. The left circumflex artery, which supplies the high lateral wall of heart, also originates from the left anterior descending artery, the same artery which supplies the anterior wall. So if we have occlusion, so if we have proximal occlusion or thrombosis of left anterior descending artery, we may also have our thrombosis or occlusion in the left circumflex artery. In this way, anterior wall MI can also present with high lateral wall MI. Similarly, you can see here elevations in lead V2, lead V3, lead V4. This is our anterior wall MI. You can see hyperacute T waves in V4 and V5 and V6 and V3. This is again is our anterior wall MI. So this is an interesting ECG. What we can see in here is slurring in lead 1, slurring, small slurring in lead AVL, and slurring here, here, and here, small, a little depression over there. In lead V1, we have a small ST segment elevation, but what is more important is T wave inversions. Alright. Again, this is our ST segment elevation with accompanying T wave inversions. Elevation, elevation, elevation. So this is our anterior wall MI but the area is so damaged that we can see slurring in the reciprocal leads. So this is our anterior wall MI. Look at this, this is called tombstone of Graves. Sometimes when the amplitude of ST segment elevation is this high and it is making the morphology like this, it is called tombstone appearance. And what is the significance of tombstone appearance? Well, it means that it has poorer prognosis. The patient is going to die soon if we do not interfere or intervene. So here we have our lead one. First, we should look at this block. This is almost of 10 small blocks. So we have 10 millimeter per millivolt ECG. This is our lead one, which has ST segment elevation. The contagious lead for that is AVL. We have ST segment elevations here. Then if we look at lead 2, lead 3, and lead AVF, which are our inferior leads, we will see ST segment depressions, and similar depressions in V1, V2, V3, V2, so on and so forth. So this is our isolated lateral wall MI, high lateral wall MI, which occurs because of occlusion of left circumflex artery individually. So I think that's it for today. I hope you learned a lot. If it added value to your education, you should consider subscribing and wait for the next video. Give me a thumbs up or comment down any recommendation you have for this channel or any video you want me to make. Now I will see you in the next one. Thank you.